Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have here a patient who attended with a completely blocked left and right ear, and this patient has Down syndrome. And the reason I make specific reference to that is because patients with Down syndrome are significantly more likelier to develop both earwax buildup, so ceruminosis, and also middle ear infections. And that's because they one of the characteristic phenotypes of patients with Down syndrome is very narrow ear canals and also eustachian tube. So the eustachian tube is the pressure equalizing tube and the drainage pipe that connects the middle ear to the cavity behind the eardrum to the back of the nose. And this patient has to tend every 9 months or so. So it is quite a common reoccurrence. The patient's fantastic. They're still throughout. They've become very familiar with the procedure. And you can probably just see there how narrow the entrance of the ear canal is. It's actually completely shut. And I have to open up the ear myself. And I do that. So this is the patient's left ear. So the way I open up the patient's ear is I've got the instrument in my right hand, and whilst I'm holding the instrument, I'm pulling the ear, so the pinna, which is the satellite dish, the cartilage on the external part of the ear on each side of our heads, I'm pulling that back and then up. And what that movement does, it helps to straighten the ear and also widen it. And then to keep the ear ajar, keep it open, I then insert the endoscope into the ear. And the right-hand side of the endoscope, I'm using that to push the ear and keep it ajar to the right. And so it's almost like a doorstop, and I'm using it also like a crowbar, the endoscope. At the same time, I'm then visualizing the wax, and then I then let go of the ear with my right hand with the instrument in, because the endoscope's keeping the ear open. And then I slowly insert the suction probe into the ear, wanting to avoid the front and the front part of the ear canal as I do, which then allows me access. So I can just see a bit of the eardrum there. You can see that blue tinge just hidden itself behind the suction probe. But this consistency of wax is very difficult. In fact, it was wax, but a higher consistency of dead skin. And dead skin that has been macerated, it's softened, which makes it really hard to use. And I've reverted to the fine end suction probe because it was getting a bit noisy for the patient. And I think in part that's because they've got a narrow ear canal. It's a smaller volume. And when you've got a smaller volume, it's increased pressure. And so sound is sound waves, the pressure waves. So that generates higher sound pressure waves in the ear. So it makes it a lot louder for this patient because the entrance of the ear is really, really narrow. So it's enclosed the sound within the ear. And the fine end, fortunately, I was able to remove it. I was a bit worried because the fine end is more likely to get blocked with this type of wax because it's sticky, mushy, and it may not have been powerful enough to remove. But as you can see, I'm slowly bringing it out. So at normal resting state, this patient's left ear is virtually shut. Now, there is a bit of an opening so the patient can hear. Sound is still getting through. And once you're past the outer half, so the lateral half, the inner half, so the more medial part of the ear canal, seems relatively normal in terms of shape. You can see it's quite wide. It's just getting access into that. And when you've got a narrow ear like this, it prevents the efficient migration of earwax out of the ear. So earwax, in the most case, migrates itself. It comes out the ear by itself. Our ear secretes earwax. And the skin that lines the ear canal, as it dies and sheds, it moves sideways out of the ear like a conveyor belt, and it's replaced by another layer of skin underneath. And it's a continuous cycle, so that conveyor belt motion of the dead skin then transports any earwax sitting on the surface out of the ear. Whilst we had the patient here, I just wanted to get as much out as possible. And the patient could hear much, much better already. Because it's such a frequent build-up, I just want to get as much out as I can so it lasts as long as possible. So we can see the top half of the eardrum, and I'm just trying to get this bit in the inferior recess. So near the eardrum there's a little trench there almost, and wax is built up in there and dead skin. The main difficulty of this patient here is not only the narrow ear, but as you go past the the middle section of the ear, where the ear then widens, the ear canal drops, it comes down. So all of our ears, or most of our ears anyway, sometimes it can be the opposite, but we should have a natural incline. The ear canal should go upwards, as an upward slope, upwards trajectory of around 30 degrees. And this patient has got that at the entrance, but then it suddenly comes back down. So you've got this peak around halfway in the ear. And it can just make it a bit difficult to get the instrument in and the endoscope in together. You can see we're doing okay. So I'm just going to stretch it. You can see, you probably saw my glove there. So that was my, the hand that I've got the instrument in. Just to stretch the ear open. And I went in with the endoscope. I had to come out. This didn't feel like I stretched the ear enough. So I've just gone in a bit further this time with the endoscope. And I'm keeping that ear wide open, as you can see. And now I'm into the ear with the instrument, and I've just got some wax skin off the roof of the ear canal wall near the eardrum. So that eardrum looks quite good, looks healthy. It's quite bendy actually. Now that I'm watching it back, it veers off to the left quite a lot. So I think I just struggled there to keep the ear open. So I started again, got the endoscope in position, stretched the ear open, and it's just a bit of this skin wax at the bottom, just trying to hover over. I don't want to graze the patient's ear canal. I think in a moment I decided to leave it because I felt as though I might scratch the ear inadvertently, and I didn't want to do that. So this is the same patient, but this is their right ear. This ear was slightly wider, but again, I'm going to pull. Now I'm using my right hand and I've got the instrument also held at the same time. I'm pulling the ear the opposite direction. So the right ear, you pull it back and up, so to the left and up. The endoscope goes in, then I'm using the left-hand side of the endoscope to stretch the ear open towards the left, which then widens the ear canal, which then allows me to insert the instrument. The reason why I'm explaining some of the technical issues is so it just helps you kind of understand the procedure a bit more, and why sometimes I'm a bit close to the wax. That's because I'm having to put the endoscope into the ear to stretch it open, so by virtue it's going to be a bit closer. And also I know a lot of our clear wax specialists who have attended our training course, who are looking to attend maybe, they do watch the videos for some technical tips and hints. So hence I thought, well, I'll explain it in depth. And you can see there's a bit of dry skin there as well at the entrance. So the patient has got kind of superficial otalgia externa. Eardrum's not visible. They've got what we call the beginnings of an autoatecotomy. So the top part of the ear canal near the eardrum, there's a piece of bone, and we call that the scutum, and that's just slightly eroded because the eardrum has been retracted because of their narrow eustachian tube, and that bone's eroded because it's just been starved of blood supply. But that's probably for another video, I think, where I can explain it in more depth. Well, I hope you enjoyed that, guys. Take care, keep well, and speak soon. Bye.